right. So using stage one, we introduced a couple weeks ago the stages of treatment, and what we want to do is help you learn to kind of walk through each stage as we move through the rest of the training. So we're going to begin with using stage one. And so I'm going to just walk through here, give you examples, and answer as many questions as I can over the next little while. And if you have a question, make sure you holler out, because we want to make sure that you are in a place where you can start to use it. Any questions before I begin? I'm going to assume that silence means no. All right. So just to review again of the treatment structure, we call it the Empowerment and Resilience structure, and it's a 4-stage model. The first one is relationship building. The second one is the psychoeducation and self-regulation. The third one is any model of treatment that you're trained in and know how to use. And then the fourth is the post-traumatic growth and resiliency building. So what I'm going to focus on today is just the relationship phase of it. So generally, when we start talking about the relationship building phase, what our goal is to make sure that whatever we do accomplishes a couple of basic things. First and foremost, that it gets us connected to the client. In other words, we are able to attach to them, that we are able to form an emotional bond with them, that we are able to begin to get to that place where we create safety for them, because we are providing that a level of connection to them that will allow them to feel safe. And we use a process to accomplish that. It's not just, being a really nice person and being, kind of non-judgmental and non-threatening, but it is actually a much more active process than that. So I'm going to walk you through these pieces of it and kind of explain how they would be used and how to best begin the process for understanding how to structure the initiation into treatment through this process. So the orientation and acculturation, which is part of the creating safety and stability, predictability, and transparency for your client. If you think about what is the goal of this in the relationship building phase, it is to create an environment where you're not activating the sympathetic nervous system, which is usually dominant for most of our clients. So how are we doing that? Are we looking at what we do and asking ourselves, does this have the potential to activate a client? If it has the potential to activate a client, we want to repackage what we do in a little different way. So we're going to start with the first piece of that, which is creating a safe environment. And that requires us to examine all aspects of what we do with the client, piece by piece, and kind of reflect back, is this going to keep them out of being activated in that sympathetic dominant state? If it's not, we want to redesign it a little differently. So what are the things that, let's just begin to kind of look at that. As the client has contact with us, what are some of the things that are most likely to activate their already aroused system, to put that system that's already on guard and on alert, to bring it fully alive in its threat awareness. Some of the things that we can do with that is we don't adequately prepare them for what's going to happen when they come in. And so the whole process of intake can be very much of an activator. And then we are often probing for information without setting a safe boundary. So let me kind of give you an example of some simple things you can do. For example, I have a rule. It's a really simple rule, and it's really the only rule we have initially. And that is that you don't say anything in here you don't actively choose to say. Well, what does that do for the person that is sitting in your office for the first time and they're worried about what? The kinds of questions you're going to ask, the kind of answers that you're going to expect from them, and are the answers adequate for what you're looking at? And that kind of internal pressure for somebody that's already pretty dysregulated can really push them over the edge. Welcome.
Hi, sorry.
So turn your mic off, Andy.
Okay.
I'm thinking you're the noisy one.
Where's mute? Here it is.
Yeah, there it's better. So this creation of the safe environment, setting a rule that don't say anything you don't choose to say, for example, allows them not to be activated by the fear that we're going to probe into areas that they don't want to explore. The other piece is a lot of times, particularly in families that have been dysregulated for a generation or two, there are many specific memories of things that can be, upsetting, but there's more of just patterns of operation that are upsetting. And a lot of times what we find is therapists, as they begin to kind of probe in that process of intake, is they're trying to look for something specific in what is really a pattern of behavior. And they haven't put the energy and time in yet to get to know the client well enough to realize that it is a pattern of behavior and they're looking for an event. And that pressure to kind of discover an event can also activate the client. So those are just a couple of examples of things that, and there's many, many things that can possibly dysregulate your client that you think about. How do we greet them? How do they, how are they welcomed into the environment? Is the paperwork that we're going to expect them to understand written in terms that they don't have the capacity to really understand? Do we have ways of explaining everything we're doing in really simple processes so that it doesn't sound like we're really kind of talking over them? That becomes kind of fundamental to creating a safe environment. Does that make sense to folks? Do you have a question about that? I'm going to assume again, silence means no. Okay. The next part of the orientation and acculturation process is really being able to address what is the healing process that will go on here. Fundamentally, one of the things that almost everybody that's been dysregulated on a consistent or a long-term basis will experience is because of the nature of what's gone on, they have become overly focused on the negative, the hurtful, the possibly painful, and become overly focused on reactions to or ways to mitigate that. So as we begin to look at the healing process, one of the outcomes of their state is very little belief that they can be better, very little confidence that they can move through this and recover. And so what we want to do in talking about the healing process is kind of capture that and actually create or begin to create a sense of empowerment, a sense of faith that it can be significantly different than it is. And how do we do that is basically give them a number of examples how people can move through this, how prior people have moved through this, and let them know essentially that no matter how they move through it, whether it's fast, whether it's regular, whether it's slow, whether they do it with ease, whether it requires work, or whether it's very difficult, that they will move through it. We want to give them examples of what that is like. And I suggest 2 or 3 examples of people moving through it fairly quickly, a couple of examples of people moving through it with some struggle, and a couple of people moving through it with some difficulty. Because what you're doing is you're basically saying, regardless of how you move through this, you can get through it. And that builds a beginning of possibility for them. So you talk about the kinds of things people begin to notice differently. You begin to kind of set the stage for the kinds of changes that people will make in therapy, and you schedule that, if you will, in a process for them so that they begin to see it. And that's part of helping them understand that the healing isn't a wave a magic wand and tomorrow I'm better, or it's not a fairy tale or a magic bean version of, fix this right now, that it is a process, and you describe it in a process to them so that they understand that we're going to move across this however we move across it, and we'll get through it, and however we do that will be right for us.
Robert?
Yes?
Would you recommend doing this even if somebody has been through multiple therapists before coming to see you?
I would recommend people do it, especially if they've had multiple therapists before. The reason being is most of the time what they've learned from those prior therapeutic experiences is that they're going to fail.
Yeah. Okay. Yeah.
So we want to give them a different view of it. Good question, Melissa. Anybody else?
Sorry, I couldn't unmute.
You were talking on mute. We couldn't hear you. I'm sorry.
It's been a long weekend. Our agency requires us to give a literacy test, and I don't like it. I think it's mean. You guys really walk in every time I'm talking. I think it's traumatizing. So I don't give it. I mean, I say I do, but I don't. I don't know how to get around that to make sure that they can read, but I think it's embarrassing if I give them 5 or 6 words and they don't know how to read it. And because one of the reasons partially that they're traumatized is because they can't read. That makes any sense?
Sure. What is the purpose that they want to give the literacy test to your people?
Funding. We're a federally qualified healthcare agency, so it's meaningful. There's all this meaningful use because we have electronic medical record. I don't really know. I'm not going to lie. It's just part of the things we have. One more thing that they throw at us that we have to do.
Well, you're dealing with people that, if in most cases, particularly if you're doing federal funding, you're dealing probably with the community behavioral health client.
Mm-hmm. Yes.
So what we know is that many of them have had difficulty educationally because the system that's on, that sympathetic dominant system, is not a good learning system. So we know that's the person we're working with, and we're going to administer a test, which even with people that aren't sympathetically dominant sometimes get activated by. What I'm going to suggest is, rather than doing that, because it's counterindicated for creating a safe environment, would be to take what it is that whatever they're expected to be able to know, and find very simple, maybe even excessively simple. Somebody needs to turn their mic off. Is that you, Shannon? Yeah, it was. You need to find excessively simple ways to kind of explain these things to help the client feel safe. One of the things I really like about doing this with the whole family is I target all of my explanations for that 5 and 6-year-old kid, and I find if I can explain it to the 5 and 6-year-old kid, guess who else can understand it? And so a lot of times my explanations may seem overly simplistic, but the folks know what I'm talking about. So I would really lobby to have that removed from your process as being something that will create a barrier to the client feeling safe in that environment? Good question. Any others? Once again, this requires you to have, as the therapist, understand the process of therapy from the beginning to the end and how people normally move through it. So if you're in a situation where you never actually get people all the way through through their therapy before they quit coming, then that's going to be a little bit challenging for you, and you may want to visit with other folks that, even in this group, that have helped people move all the way through treatment, so you can have a better vision of what it looks like. So next, what is it like to work with you? This is a time for self-disclosure, which makes a lot of therapists kind of uncomfortable because they have been told there shouldn't be self-disclosure. Unfortunately, that rule doesn't work with human beings. Human beings form relationships through acts of reciprocity, and that one of the primary ones is kind of a self-disclosure. So you cannot expect the client to disclose at a level, particularly early on in the therapeutic relationship, disclose at a level more than you disclose. That is why we suggest, hello? I'm going to mute that person if that's okay. Who just came in, you're really noisy. That's better. So what you're going to do is kind of over disclose, if you will, to some extent. And this sets up the concept for you to stop sessions and do the modeling that we talked about before. It helps you talk about, sometimes you get lost in sessions and you get caught on one idea and you forget to listen to the next. And you talk about things that are normal human weakness that the client will experience just in a day-to-day life, and you own them. This allows them to see you being human, and that when you are fully human, that you have strategies to deal with that. So that,
Robert?
go ahead.
Sorry. Do you think it's necessary to actually verbalize that piece of it, or can that be just something that you model in your work, as far as, like, stopping a client and saying, okay, you lost me, or I'm having a really hard time following you? What would be the benefit, I guess, of talking about that up front versus just modeling it?
Because it basically, you're looking to establish the relationship you have with them. It is part of what you can use to do that. So also, if you have already set the stage for it, that's saying, that sometimes you get lost, or you lose your place, or you get caught up in what's going on in the session, and you get distracted. What you're doing is essentially modeling for them that it's okay to admit that those things happen. Why is it okay? Because the therapist is saying that they deal with that too.
Okay.
You're also going to say that when that happens to me, what I'm going to do is stop and get me collected so I can fully focus on you.
Can I jump in too?
Sure.
So I think that one of the benefits of this is definitely creating that predictability. And when we can take ownership of it as, like, this is something that happens to me. I get lost. In my experience, sometimes I can't follow. so that we're taking that full responsibility, and then it takes the pressure off of them that, you know, they're the ones going too fast or too slow. They're always going just right, and we're the ones who sometimes can have a hard time. It gives them permission too to do that same thing, like, you know, Dr. Roden said.
Does that help, Melissa? I'm going to assume that quiet means yes.
Yep, sorry. Yep.
You also, you can also address, these are the areas that I'm strong and these are the areas where I'm weaker. And because I recognize the areas that I'm weaker, then what I'm going to do is make sure that I really focus on not letting those areas of weakness interfere with your sessions. And I don't know if you can appreciate that. If you haven't done that with a client, watching them kind of relax when you say, you know, I'm pretty fallible. I have things that I'm pretty weak in, and because I recognize that about me, I'm going to work really hard at paying extra attention to this particular situation, so that I don't let that interfere with your therapy. And I also usually share with people that I'm pathologically optimistic. So these are just examples of things that, and to be honest, for most people, this is such a different concept, because most therapists really don't want to show weakness. They don't want to really show that they are human and that they struggle with the same things everybody else does. Because, of course, then why would anybody want to come to you for help if you are also a person that struggles with the same things everyone else does? However, remember, the purpose of stage 1 is to forming an attached relationship. And they are much more likely to attach to a person who is another human being, not some distant expert that doesn't have any of the same experiences that they have. So you just lay it aside. Lay aside the ego that we normally have and just be one human being visiting with another human being. I don't know if that helps, but that's kind of how we conceptualize that. The next thing you're going to do is kind of talk about the format of the sessions. And you're going to talk about why they're the same. One of the reasons that they're the same each session is that one of the things that we find clinically that makes things work better is when there is a uniform process or a ritual or a routine to what we do clinically. And therefore, we're going to run sessions approximately this long, and they're structured this way, and we will run them the same way each time. And these are the things that are going to be part of each session. So, so if I was doing this for a session that I was doing, I would talk about, because it's generally family sessions, I would talk about how the session's usually 90 minutes. And what we're going to start with each and every time we meet is a review of the feedback from the session before. And I will have gone through it before you come in, and we'll go through it together. And what my job is to take that feedback and adapt and change what I do to fit you guys better. And that becomes my job. Each and every time I get feedback from you is to improve what I do with you and make it work better. Once we've accomplished that, then we'll spend probably 70 minutes on what we're going to work on for the day. And then my little timer is going to go off. And I'll even pass the timer around so that they can hear it chime. And when the timer goes off, I'm going to pull out my laptop, and I'll probably even just pull it out and show it to them as I'm orienting them. I'll pull out my laptop and I will open it up so that we can do the notes together. Now, the reason we do the notes together is so that I know what you're thinking, you know what I'm thinking, and once this is in here, I don't ever add to it or take from it. So you know exactly what your record shows. You don't ever have to guess. You don't have to worry about it. It is straightforward and you know. And then once we finish that, we'll go through and give you the feedback sheets for the following that we'll go over to start with next time. And what I do with the feedback sheets, just so you have an understanding of how to maybe use them a little easier, is I actually give them multiple examples of what positive feedback looks like. I give them several examples of what neutral feedback looks like, and I give them examples of what negative feedback looks like. And I always encourage the negative feedback, because after I give them a number of examples, I will ask them, which do you think makes it easier for me to adapt and change what I do to fit them better, to fit these people better? And of course, it's always the critical stuff. So what I am actually putting them in place of doing is being the critical consumer of their own therapeutic process, so that they're constantly looking at it, asking the question of what can be done to make it better. And that is really useful for folks. I cannot overemphasize that. Now, there's lots of different tools for using it. Different companies will accept different things. A lot of people use Scott Miller's, the OSR, the SR, and the SR, whatever it is, and the ORS, and they are useful tools. I like a narrative, so that I actually have written things that I can talk about with the client rather than just a score. And I have found it to be incredibly helpful. Questions about the format of sessions and why we would do that? No questions? I'm going to assume everybody completely understands that and is ready to implement it. All right. The next piece that we want to make sure that we include is what biases we might have and what our philosophy of healing might look like. Now, where a lot of people have traditionally talked about their biases as kind of problems in therapy, I look at biases a little differently. Remember, everything you do in stage one is to connect with the client. So I'll share a bias, but my biases that I'm sharing with the client are always to engage the client. So let me give you an example of one. One of my biases, particularly in working with children and families, is that you have multiple partners or multiple systems involved with the kid. And I know that if parents are involved with Child Protective Services, there's almost an adversarial feel to that, and they feel judged and they feel disadvantaged by being involved with Child Protective Services. It should make sense to everybody. So one of my biases is this, and it's a really easy bias to kind of share with them. And I just apologize. As we kind of go through the process of working together, there are probably going to be times when we are with other organizations and people from different, systems partners that want to have input into what's going on. And I have to be really honest. One of the things that just sets my teeth on edge and makes me really kind of angry is when one of these people seems to be suggesting that the families are not 100% invested in the welfare of their children. I've just never found that to be true. There are parents that have some fears. They have some parents that have had life experiences that are pretty awful, and they don't have maybe some of the skills that they might appreciate having. But I've never found anybody that thought I was such a nice guy that they were willing to turn their kids over to me and just not care what I did with them. That's just not true. And so when I hear that from a school system or a Child Protective Services or even a probation officer, I'm more than likely to stop the entire process and take them to task for that. And sometimes I'm not very nice about it. So I just want to apologize up front. that, it's one of my pet peeves and biases towards the way the system operates is the attitude the system has towards parents. Do you think I hear them tell me they don't want to be involved in the treatment of their child after that? I just don't hear it. I'm always surprised when people say, well, how do you get the parents involved? And my question to them is, how is it that you don't? Because that shows kind of a lack of our ability to engage them. That biases should always reflect that you are on the client side of things, and you use your biases to get buy-in from the client. Do you think your clients have any biases? How many of you have worked with someone in a substance abuse program? Do you think that there isn't biases built into the substance abuse program, that there are things that are punitive to the client that you can have biases around that will actually tighten and increase the closeness of the relationship you have with them? So one of the things that's really common to a lot of programs is, one of the things in this program that I don't agree with, and I have a bias against it, is that when people, relapse through the process of healing, that they are discharged from the program. And I struggle with that because I don't think it's the right thing that we should do. Now, some people say, well, you're actually criticizing the program. You shouldn't do that. But what I'm actually doing is bonding with this client. I am being their ally. And that's what you're doing in the early session, the early part of therapy, is forming and maintaining this relationship. Does that make sense? So, okay. Yes?
I wonder if this works with what Shannon was saying too earlier in terms of what her company has her do with the literacy. That
Yeah.
you could use the bias and how she doesn't like the way that this is something that the company has to do, and kind of use it that way to help explain some of the biases.
Sure. Well, and what it does is let them know that this isn't something that you think is a particularly good idea. So you're kind of on their side. I think that could be a great avenue for that, Megan.
I think I'd have to have a whole nother session on the things I don't agree with that my agency does. I think that would take up way too much time, and it would probably be a little too negative.
Well, you probably wouldn't want to have more than a couple of them.
No.
But
No.
whenever you use a bias, you also want to talk about how you are going to address it for them. So, like I was talking about taking people to task when that comes up. If I was going to use something like this, that there's a literacy part for my work, I might say one of the things that I'm always concerned about is, and actually give them the reason why I don't think it's a good idea, but we have to do it, is meeting part of the criteria that to get you into services. And I would just apologize for it, those things that I don't agree with. And, it's one of those stinky things that we sometimes have to do that we don't like.
I just had a quick question. Would bias kind of be the same thing as like trigger? Because mine would be when divorced parents who will a lot of times come in to sessions. Well, if I have divorced parents, I make them both sign for consent anyways for their kid to come to treatment. But I will sometimes get them to come into treatment, and when they fight in front of a kid, that's a huge, I'll lose it sometimes on them. Is that kind of the same thing you're talking about?
So if you wanted to, yes, you could use that. So let me kind of tell you how you might structure that so that it's a connection rather than you creating another barrier. So if you working with families where there's a lot of divorce, and that's a common thing that comes up, then you want to talk about, I have a real bias that it isn't appropriate for parents to argue in front of their children. particularly when we're struggling to kind of regulate and help the child function better. So what I do with that is when it occurs, and it just naturally occurs as part of therapy sometimes, so we're not going to worry about it a lot. But one of the things that I will do is I will interrupt the process. And I'll either ask a question or I will in some other way interrupt this. And I'll interrupt it as many times as I need to make sure that we're creating the best environment we can to help the child. And that's just a bias of mine that we need to make sure we aren't arguing in front of the child. That way you are their ally in helping the child. But you're also kind of suggesting what your bias is. Does that help, Shannon? Okay.
Yes.
All right. So are there limitations in your settings? If there are any, you need to kind of discuss what they are. And every setting has some limitations. You want to talk about what the limitations are clearly. You want to talk about what's realistic to accomplish in your setting. And you want to use the limitations to connect with your client. A lot of times we will talk about limitations and we actually are building barriers to treatment. What you want to do is use the limitation. So let's say you're in a place where you only have 10 sessions. Then as you're kind of talking about what that's a limitation, we have to kind of look at how much we can actually accomplish in that time and what that might look like. That becomes part of engaging the client around the limitation itself. And you want to use your limitations to form working alliances with the client. So that's kind of that piece. Want me to talk about any of those more, or are we good to go to the next slide? I'm guessing that silence is go to the next slide. So the next piece that you're going to do in the orientation and acculturation is talk about how to approach transitions in treatment. You're going to introduce the stages of treatment. You're going to discuss the concept of stability followed by treatment. In other words, we stabilize first, then we treat. And we talk about how people move through stage one, what people see that lets them know that they're ready to move into stage two, and what's moving into stage two might look like. When you're in stage two, you're going to do the same thing about you're going to describe what it's like to move through this stage, what people will see as they move through it, how they'll know when they're ready to move into three. You're sketching all of that out for them. So that's, so that they understand that there is a beginning, middle, and end to each stage. There's a beginning, middle, and end to therapy as a total process. And that it isn't just, it's structured and organized, and that they can be successful at it. The next piece is actively regulate the sessions through modeling self-regulation. We kind of talked a little bit about that when we were talking about the physiology piece, but this is actually modeling your own skills at regulating. You don't want any of these things to be more than 60 to 75 seconds long. You don't want them to require any kind of artifact other than the body itself. So some people might have, a relaxation rock or a fetish of some kind that they have imbued with some kind of thing that they want to use for relaxation. The problem is that if they're not in the presence of that thing, they've tied all of their self-regulation to these external objects. So you always want to bring the self-regulation back into the body itself. So any activity you do, you want it to be housed, something that they can do quickly and something that requires the body to be involved. For those of you that took the CCTP training, one of the exercises that I know Eric and I both do is the one with the hands up behind the head with the elbows back. Have you remember that one? Where we are putting people, where we're kind of moving into a set of diaphragmatic breathing simply because of the way that you breathe when you're in that stance. And then you use your voice and your tone of voice to modulate them through relaxation. So this requires each and every person to have 15 or 20 of these that they use on a daily basis for themselves. Now, what's the benefit to you as a therapist? Number one, you don't finish your day being exhausted and overwhelmed because you're regulating through every single session with people. So that kind of makes life a little easier. Two, you also help your clients that are in a state of dysregulation, and learning is not a thing that they're going to do well, to actually be able to pick these up indirectly. A lot of times you want to stop and teach. You should never be stopping and teaching in stage one. It's not appropriate. You haven't got the appropriate space yet to do that. Questions about that idea? I'm going to again assume quiet means no.
If they ask about what you're doing, you just want to explain to them what you're doing with regard to self-regulation, and bring it back to what you said at the beginning, how sometimes you lose track and you need to pull yourself back together, but you don't actually want to tell them exactly how to do it. Is that what you're saying?
That's correct. You own it. You regulate. So remember when I said before that I sometimes get lost, I get caught on one idea and I forget to listen to the next idea? I'm having one of those moments right now. Now, you're not done at that point. Then you tie what you say your experience to what you see in them. So if I've seen their chest tighten up and their breathing change and their muscles in their neck and face have tightened up a little bit, then that's what I'm going to use as the second part of this. So I've kind of lost my place. And what I notice about me is when that happens, sometimes I feel this and I describe the physical thing that I'm seeing in them. And then I regulate, I go ahead and regulate me. And as I regulate me, I describe not only what my body is experiencing, but I describe what I'm also, if you will, my sensory difference is I'm able to focus more, I'm clear-minded, and I can feel, whatever you're going to feel in your body. So you want to house it in not only the body itself, but also in the thinking process involved. And you want to talk about the benefit that you're getting from it. I can sense as I'm doing this, that my thinking is becoming clearer and more or less confused. So what you're doing is essentially helping them regulate their own body indirectly. Now, why do this other than the fact that you have to be the external regulator anyway, is early in sessions, is the other piece of what you're doing with this is you're modeling a number of different tools. What we tend to do as therapists is the ones we like are the ones we tend to teach people. And if you have 15 or 20 of them, some of them are going to be less your primary ones than others, because you want some that are, kind of broad spectrum. And you're going to find your clients are going to gravitate to one or two over others. Now, the natural transition of this, what I do when I move into stage 2, is I'll do the same thing, but they've seen me do this through 4 or 5 sessions by now. I'll begin to ask. I kind of got lost again, and I'm noticing this, and I'll describe what I'm feeling, what I see them feeling in their body, and I'll actually ask them, which of the things you've seen me do might be the one that would work the best in this situation? And I actually get them to coach me through my own strategy. Do you think they've learned it? They've usually got it cold. The other thing is that they're probably starting to experiment with it on their own, because they've felt what it's like in the session to regulate themselves, or have me regulate me, and they have felt that as well. Does that help? Okay. So let's move on to the next piece that you're going to accomplish in stage 1 is to begin to the assessment piece. And there are both informal and formal assessments. An example of an informal assessment can be the timeline. And what you're going to do with timeline is kind of identify what are reasonable beliefs about themselves and the world that they live in and the relationships from the history of their own experience. What are reasonable fears and concerns? What kind of drives do they have to deal with those concerns or fears? What themes are you noticing? And that you're going to pull all that out of a timeline. But some people like more formal than informal ways of assessing, and that's fine. But you're going to do your goal in doing this isn't to collect information alone. It is to build capacity as you collect information. So how do you build capacity is the way you use kind of language with this. So if I've got my timeline and I've had people score it based on how disturbing it was when it first happened and how disturbing it is today, there should be a difference in that. If that difference is more than a couple of points, then what I'm going to do is start assuming capacity on their part. And I'm going to begin to ask questions like this. What's the first thing you noticed about yourself that was different as you moved from this original 8 to the 4 you're at now? And as I go through the timeline, what I'm going to do is continue to tweak and change the viewing of it, and I'm going to build strength and capacity in that as I go through it. And that strength and capacity will help them view it from a different point of view, but it also, for the first time, gives them themselves as an active agent in this process. Now, that doesn't necessarily mean that they really ever did anything. Maybe 25 years went by and that's what's really happened. I don't really need them to be able to recall a specific thing. Just asking me the questions begins to do the work for that. Questions about that?
When you say create capacity, can you speak more to that?
Sure, because you're dealing with a more subtle use of language in that aspect. So you're making some assumptions. If you think about, if I were to ask, for example, Shannon, what's the difference between the Shannon right now and the one that graduated from college? What am I assuming is that she's able to take her experience and organize it in some way, that she's able to kind of distinguish differences in herself, that she's able to order those differences, that she's able to speak to those differences, and that she actually has some internal criteria for evaluating the change within herself. I'm communicating all of that at a level of subtlety that builds belief. If every question you're asking is kind of doing that kind of instilling, if you will, of capacity, then you change the entire view of their experiences. Because time after time after time, you are reinforcing that they are strong, that they are competent, that they're powerful, that they have the ability to do this again and again and again and again. And so you'll see people that are really dealing with some pretty fearful things feel very positive about the session when it's over. Not all tied up in their emotions, but actually leaving feeling like they've been powerful. And that's a new feeling for many of them.
Is that similar to motivational interviewing?
No, motivational interviewing is kind of manipulative.
Okay.
What you're doing is just highlighting, you're actually creating, if you will, a view that they didn't have before, Kevin. Because what you're doing is focusing on them, focusing them on creating, if you will, a memory of them being powerful. You're not trying to manipulate them into changing, a readiness or to take an action. because the question already assumes that they've taken actions in the past and that those actions have helped them create whatever changes that they've already experienced.
So it's helping them recognize what they have achieved,
Mhm.
which increases their capacity, saying, "Oh, I'm capable of doing this.
Sure.
I've been through this much change. Wow, I hadn't looked at it like that."
Not only is it, you're not just highlighting, you're actually creating. Because remember, the medial prefrontal cortex has been offline for a good bit. So there's big gaps where there's no picture or there's no timestamp on a picture. And so what you're doing is creating new pictures to insert in this sequence. And the new picture shows that I actually was strong here. Does that help?
Definitely.
Okay.
I have a quick question. So I caught on to what you had said earlier around, you said stage 1, and then you said, they've been watching me model this for 4 or 5 sessions now.
Mhm.
So I'm actually also looking at the article that you referenced earlier that continues to sort of outline the steps in each stage.
Uh-huh.
So which pieces of stage 1 would you say should happen at intake, and which pieces are okay to leave for further sessions, like 2, 3, 4?
What I try, rather than saying this one's good for this one and not good for that one, is I base it on what I'm getting from the client as I move through it. So some clients, man, they come in and they're ready to dig into stuff, and you can move really quick. Other clients, you have to be so gentle as you move them because they're so fragile. So there isn't a right answer to that question. It is or if the right answer is, you always base it on what is the maximum that the client can tolerate without becoming dysregulated more than they are. That's probably not a very satisfying answer, but
No, it's fine. Yeah.
Do you have any more? You recommended last week the Hope and Resiliency by Dr. Dan Short.
yes.
Do you have any more readings that kind of explore building capacity and creating capacity?
Did you already read that one?
Bam!
Good for you.
Yeah, halfway.
Now, so before I recommend somebody else, because his material is very good, how much of it are you implementing?
I mean, as much as I can. I don't know. I'm trying to implement it. It makes sense to me. Well, I understand the highlighting part, and that goes back to the phase 1 being optimistic.
Mhm.
I feel like a lot of creating capacity is the perspective and showing, hey, let's see this. A month ago you were here, and now you're here. What was that? But
So
I guess creating versus highlighting is difficult.
Well, the highlighting piece. So if you've been working with them a month and you're getting ready to move them to a different stage of treatment, well, a lot of times what we do as the therapist is tell them how good their movement has been. What you would do instead with capacity building, which is what Dan's trying to talk about there, that highlighting piece is, what was the first thing you remember that you were able to do to take and make an active decision to move from where you were to where you are now? You hear how that's a question that's going to reflect their own personal strength. But somebody is really noisy. Sorry. Aha. So I don't know if that helps, but essentially, before I make another recommendation, I'd like to see you play with the material in there for a few weeks, because it takes some time to develop some skill at using it. But I can certainly point you in some other directions. One of the ones that's kind of fundamental to the what we would be NLP was when words were magic. That's another really good one in talking about how to use language to move people. But I'd rather you kind of actually get a good handle on what you're doing with that material you already have. And good for you for acting on it so quickly. So let's
Amazon.
So what are you going to be looking at in assessments? And there's a lot of formal ones, and Tracy's going to spend the next several weeks kind of talking about assessment. So you'll get more of this. But when you look at an assessment, you're always going to be looking at the developmental history of trauma, loss, and grief that people have experienced. What lessons would be natural for anybody to learn in that history, which would generate beliefs and rules and roles and habits of thought and habits of emoting and even habits of using the body that they have, and what would be experienced normally by anybody that's had these kind of experiences. What are the likely places that they've developed sore spots, or that they have really tender places that need to be kind of not poked, if you will, like a sunburn? And how are the, kind of an understanding of how the maladaptive behavior is actually an attempted solution. And finally, what strengths are being utilized to maintain that behavior? All of the assessments you're looking at, whether they be formal or informal, are going to be evaluating these things. However, this information is only useful to you if it allows you to connect with the client more closely. So what we find over and over again, a lot of organizations they'll use formal assessment tools, they hand them to the client scores them, they look at them, and they put them in the file. And that is not what you want to do with this. You want to use whatever assessment tools you use to then connect more strongly to your client with. And it's easy to do that if you're going to go back and highlight how, what would a person have to have learned about themselves to move from this point to that point? What would a person would have naturally learned about relationships from having had this experience? And what are the times that they've also discovered that it wasn't always true? You're going to begin to explore those things rather than just check it off and move on into doing the therapy piece. So assessments are always part of how we connect with people and get a better quality of connection or attachment to them. These are some of the things, and I don't know which ones for sure that Tracy will be going through these with you. I'm pretty sure the ACE one she will. She probably also introduced to you the one that isn't there, which is the trauma recovery scale, which is a tool that Eric developed. I'm sure that she will review that, and she'll talk to you about how to score these things and work with them. So that's something you'll be looking forward to starting next week.
Is she going to give us these scales, or can we find them somewhere?
They will be posted for your use and pleasure.
Okay, thank you.
And so part of what we're also looking at is, what are you always going to be evaluating when you start looking at assessments? And these are some of the basic things that you want to make sure that you are looking at. What we have done traditionally is over-focused on emotion and behavior, and rather than understanding that when we're dealing with highly dysregulated people, those are just evidence that dysregulation has gone on. And so we don't want to over-focus on them alone. We want to be able to have a more broad spectrum of understanding the human being that we're dealing with. And so we look at these 7 domains. So most of the assessments that you're going to be looking at will be reflective of all 7 of these arenas. Questions about that? Nope. Okay. So let's talk about treatment planning. So how many of you have had highly dysregulated people come in for sessions the very first few times? You don't have to all raise your hand or yell out, but just I'm going to assume that everybody's had that experience. We have people come in that are in a state of sympathetic dominance, which means they're confused. They have difficulty even thinking through something. They definitely don't have the capacity to follow through very well. They don't learn very well in that state. And what are we asking them to do is to tell us what they want to accomplish in therapy. If they were honest, they'd say, I don't want to feel this way anymore, period. Or people are telling me that I shouldn't be doing this stuff. However, that's not a very efficient treatment plan. And so one of the things I'm going to suggest is when you're in stage 1, you want to dictate the treatment plan. When you get ready to move into stage 2, then they're regulated enough to have capacity to be collaborative. Does that make sense to folks? How many of you have done this? You have asked them what their goals are, you've made suggestion after suggestion, and what they do is say, oh yeah, that's the one I want. Well, that's not really very useful, and it's not really collaborative. They aren't in the capacity to be collaborative with you truly. So what we suggest is what are reasonable goals for the initial treatment plan are these. The client will be thoroughly oriented to treatment. If you need for your document some kind of measurable way to evaluate that, you have all the things, just list all the things that you're going to try to accomplish with the orientation, which are on the prior slides, by the way. You're going to talk about the formal and informal assessment process that you're going to go through, and you will probably even list the assessment tools that you will use to do that. That's really quite enough for an initial treatment plan. Does that make sense? So, and again, here's my rationale. Why are we not asking the client to come up with these initial goals for treatment? They are in a dysregulated state and are not in the executive functioning system adequately, and having them set goals which will open the door for them to have a failure. And they've had plenty of failures already. We do not want to activate that with them. Questions?
I'm sorry, I have one. Okay, so with my agency, I don't know who works where. I'm not 100% sure who works where, but we're regulated by the Joint Commission. And being that we're the FQHC, we have to have 25% of our goals be the client identifying community supports, and they have to be written in the client's words.
So what would be the community supports they're looking for?
I have no idea. They haven't trained on this. They just said that 25% of the objectives somewhere in there have to be community supports. Basically, they want them out of treatment as fast as possible.
Sure. So without a listing of what those are, it's very hard for somebody that's in a state of dysregulation to choose those. So if your company requires it and it's a limitation to services, then I would suggest you put together a list of things that they possibly could do to be connected with the community, and you explain what the limitation is and which of these would sound like something you'd be okay with us putting in a treatment plan. But essentially, you do all of the legwork before you require that of them.
Okay.
Does that make sense? Because
Yeah,
we do not want to set them up for failure. Telling somebody that is in a dysregulated state that they have to, that's too soon to kind of put them in, you have to get connected out here in this community somewhere when they are barely getting through the day is a tremendous extra pressure to put on a client. And what you're doing is setting them up to fail. Now, that's perfect in the way we do things in the United States, which is because really mental health services are designed to support the pharmaceutical and insurance industry and not human beings, but it's probably not a good practice. You picked up one of my biases there, didn't you?
Just a little. Every time I meet on these, I'm just like not wanting to go to work the next day. We need to start having these on like Fridays so I can recover from these sessions. You already told me like the DSM shouldn't be here. I can't do this on Sunday to go work Monday.
All right. Well, I'm sorry. We'll have to be a little bit less pejorative then with the system of care. I believe that we're pretty much wrapped up here, unless you have other questions for me.